Well, good evening, everyone. Thank you for joining us. My name is Calder Lynch. I'm the Director of the Division of Medicaid and Long-Term Care for the Nebraska Department of Health and Human Services. We'll be starting here now with our very first provider webinar related to the implementation of Heritage Health, our new integrated managed care program beginning on January 1st. I thank everyone for joining us today. We've got a lot of interest from this, and we'll be following this up with another webinar during business hours if you've got colleagues that were unable to join us today. We're very excited about the work ahead of us as we work with our health plan partners and our provider partners across the state to ready for what will hopefully be a very smooth transition and implementation of Heritage Health in January. So with that said, I'll hand it over to our staff here to conduct and moderate the discussion today. We'll have presentations from our staff as well as the health plans, and we'll also have plenty of time for questions, and I'll let Carmen kind of discuss what that process will look like.
Okay, thank you, Calder. Good evening, everyone. My name is Carmen Bacco, and I'm the Communications Coordinator for the Division of Medicaid and Long-Term Care. We're going to be focusing today on the new Heritage Health program, which is the state's new managed care integrated delivery system. We have several presenters in our lineup this evening. So joining us from Nebraska Total Care are Ryan Sadler, CEO and Plan President, Chris Stark, Vice President of Network Development, Nancy Davis, Vice President of Network, Jenny Clark, Vice President of Medical Management, Julie Rosshacker, Senior Director, Clinical Behavioral Health, and Michelle Brochu, Senior Director of Behavioral Health Contracting. From UnitedHealthcare Community Plan of Nebraska, we have Kim Manning, the Director of Marketing and Community Outreach, Barbara Palmer, Registered Nurse, Director of Health Services, Adam Proctor, Behavioral Health Clinical Manager, and Jeremy Sands, Director of Network Strategy. And from WellCare of Nebraska, we will be hearing from Laura Lee Rubel, their State President. So first I will begin this evening by going through a presentation to give everyone an overview of what Heritage Health is, the history of managed care in the state, and what it means for our recipients and providers going forward. After this brief overview, you'll be hearing from each of the health plans regarding their credentialing process. A snapshot of Medicaid in Nebraska today. We currently have approximately 230,000 enrollees at an annual cost of about $1.8 billion in actual health care expenditures that we're reimbursing or that we're paying our health plans for. Our total budget in the division is a little over $2 billion when you include the administrative costs. So
all callers are muted.
Is financed for the actual health care services. At this time, about 12% of our state's population in Nebraska is eligible for Medicaid. Currently, we have a managed care program. We've had managed care in Nebraska since 1995, and what managed care is a system of health care delivery, which the department contracts with health plans to administer health care benefits and services for our enrollees. Managed care has evolved over a number of years across the country as the states have learned more about how to administer the programs, the types of contracts they could enter into, the different federal authorities, and the oversight that exists to help govern the programs. But in Nebraska today, we contract with 3 regional MCOs, which stands for Managed Care Organization. The MCOs are contracted for physical health services for all of our enrollees. Physical health services would include hospital visits, doctor's office visits, those routine medical care services. So depending on what part of the state you live in, as a Medicaid recipient today, you'll choose from one of 2 regional health plans for your physical health services. One plan operates statewide, while the other two each operate in their own region, so everyone has a choice of 2 currently. We also have a separate managed care entity for behavioral health services that is operated statewide, and there's one contractor for managing those behavioral health services. Currently, that's Magellan. So almost all recipients in Medicaid that receive behavioral health services have those services administered through Magellan. And then we also separately have a pharmacy benefit manager that we contract with to manage the pharmacy services for the entire program and all of the recipients. So depending on where you are in the program and what services you are receiving, as a Medicaid recipient in Nebraska today, you could potentially be having 3 different entities managing your health care services, which can actually increase to 4 when you include the waiver services or in-home services that we provide. So there can be a lot of disconnect between those different systems. And one of our goals with Heritage Health that I'll talk about today is to help bring those together and create a more coordinated system. Today, about 82% of all of our Medicaid enrollees are enrolled in a physical health managed care plan, so that's nearly everyone. And with a few very small exceptions, more than 99% are enrolled in the behavioral health managed care plan. In a traditional fee-for-service state-administered program, the state is responsible for contracting with the healthcare providers that are delivering the services and receiving the claims from them, processing them and paying for them, but depending on the level of utilization, our level of cost can be somewhat unpredictable. With managed care, we use a capitated model in which we make a fixed monthly payment to the managed care organizations, and they are then responsible for managing that provider network and paying those claims. The monthly payments are adjusted based on the level of an individual needs, where they live, the relative level of risk to their health. This creates more budget predictability for the state in that we can kind of forecast our needs based on our enrollment trends and predict how much we are going to be paying each month to the health plan for those services. So those fixed rates are developed by our actuaries. They look at the trend of healthcare costs, they look nationally at what trends are coming in terms of healthcare expenditures, and they develop rates that are designed to be inclusive of the cost of healthcare services. The managed care system also improves efficiency over fee for service, as the health plans tend to be better equipped and better able to manage the utilization. They can do care coordination and help lower overall cost by reducing some of the more costly care like emergency room utilization and hospitalizations. So to compare those two models, we have the at-risk model, which the payment, as I said, is made to the health plan before the services are delivered, and the risk is assumed by the managed care organization. Whereas with fee-for-service, the state is paying for those services after the costs have already been incurred. Now, what the fee-for-service system doesn't necessarily do is reward managing better health and having better health outcomes, because oftentimes a state of health is actually a lack of health care, meaning that you're well, you're getting preventative services, and you're not utilizing health care services. So we're trying to shift the model away from that pay-for-volume and go more towards a pay-for-value. The first steps towards this goal were made throughout the past 20 years of managed care. But you'll see with Heritage Health, we're trying to go a step further by engaging our providers in that equation as well. So one of the key responsibilities of the plan that we have contracted with, for Heritage Health is care management, really putting an emphasis on primary care, preventative care, triage, and referral out for services like behavioral health and disease management. So identifying through health risk assessments those individuals that have multiple or even single chronic conditions and stratifying them in terms of the level of risk and then plugging them into different care management programs that might have different levels of intervention, from very basic telephonic checks to just say, how are you doing? Do you need help scheduling an appointment? Do you need help with transportation services? To the more intensive care management, where they have an assigned care manager in the community that may be going out to their home and visiting with them and checking up with them at different levels. So we want to see different risk stratification, different levels of care management. Quality management is really having a more formal structure, a formal plan for what our goals are around quality. What are the metrics that we're prioritizing, that we're measuring our performance for by the health outcomes? You'll see lots of national performance metrics included, like HEDIS measures, which are national measure sets around healthcare quality and outcomes. Member surveys and member experience surveys about their level of access to care, their level of satisfaction with their provider, their satisfaction with their health plan, and also more focus on engaging the health plans and helping us with performance improvement projects. So identifying priorities, areas of concern, areas where we see opportunities to improve, and focusing our efforts around them. Utilization management is another key responsibility. Looking prospectively at pre-certifying or pre-authorizing certain services before they can be administered to make sure that they fit within clinical guidelines, that they are the right level of care, and that they meet our medical necessity criteria. Concurrent review, for example, working with the provider for discharge planning when an individual is ready to leave the hospital to help determine what the right timing is, what the next level of care looks like, and making sure that there's follow-up and continuity of services. Are they getting their prescriptions filled? Are they getting connected into home health as necessary? Then the retrospective review, looking at claims to give resources and insight about what those utilization patterns look like, and maybe help lower that cost and improve their outcomes. Provider network management. One of the big reasons the states have moved towards managed care is that there are a lot of federal regulations that really limit the state's ability to truly manage the program. Health plans are better equipped and actually have better flexibility to do that. So one of the ways around managing the provider network, being able to have an individualized agreement with different providers that build in certain outcome metrics or reimbursement priority criteria. And also making sure that they have policies for continued access whenever providers change. With someone that is there to assist you in transitioning from one provider to the next, potentially if they leave the network or stop providing Medicaid services. And then having provider education, people that can go out to be on the site with the provider, help the provider with billing issues, claim issues, or the latest medical guidelines that are available. So what's happening with Heritage Health? We've had managed care, as I said, for a number of years in Nebraska with physical health and then separate behavioral health. Medicaid and long-term care is now entered into contracts with 3 plans: Nebraska Total Care, or Centene, UnitedHealthcare Community Plan of Nebraska, and WellCare of Nebraska. Each of these plans will operate statewide and provide integrated health care services, which include physical health, behavioral health, and pharmacy services to the enrollees beginning January 1st of 2017. We're working diligently to make this transition, including readiness, provider education, planning the enrollment period for members to select and enroll in their health plan, and making sure that the provider networks are prepared for the transition. With all of the goals of the program that we've identified, improved health outcomes is our #1 goal. We want to focus on seeing better quality and better outcomes for our recipients, better integration of services with better coordination across physical, behavioral, and pharmacy services, having an emphasis on a person-centered approach toward identifying an individual's needs and wrapping services around them, care management, more preventative services, more recovery-oriented care, and reducing the rate of cost in avoidable care. So really trying to examine emergency room utilization for non-emergency needs, hospitalization, rehospitalization that is unnecessary, just having those metrics in place and engaging the plans and providers to help us address those. Then, of course, the improved financial sustainability of the system. As we bring more services, more populations into risk-based managed care, it creates better budget predictability for us and hopefully lowers the cost growth curve to a manageable level so we can stay at an annual growth rate that allows us to be sustainable. One of the big changes, as I said, under Heritage Health is the integration of the behavioral health services. This is really designed to help us better identify and manage individuals that have concurring behavioral health and physical health needs. In fact, there's a lot of data that suggests that individuals with behavioral health often have unmet physical health needs or chronic conditions, and the cost of treating those chronic conditions for an individual with serious mental illness can be many times higher. Their compliance rates are poor, they're in and out of the hospital more often, they're in and out of the emergency room more often, and individuals with serious mental illness live on average 25 years less. So we really want to put a lot of focus on making sure that we're identifying those individuals and wrapping the right services around them. And part of that is just by bringing them together under one contract. You have one entity that's now contractually and financially incentivized and obligated to look across that full spectrum. With the current system today, there's often confusion about who's paying for what. If an individual shows up at the emergency room, is the primary need physical or is it behavioral? And who's responsible for them? The split in coverage can limit the motivation to make investments in those preventative behavioral health and community-based services. So by bringing all of these services together, you create better incentives to make those investments on the front end. We also know this is a big change for our system, for our providers, for our staff, to go from having one behavioral health contractor that everyone deals with to having 3. So one of the steps we've taken was the creation of the Behavioral Health Integration Advisory Committee, which includes Medicaid along with the Division of Behavioral Health, the plan, various providers and advocates, all at the table planning and making sure we're thinking through all the different things that we need to make this a smooth transition in 2017. We're also introducing some new populations into managed care through Heritage Health. Currently, some of the groups that are excluded from the physical health managed care, meaning they're completely in the fee-for-service system for those needs, are individuals who participate in our home and community-based waiver programs, like the aged and disabled waiver, the traumatic brain injury waiver, and waivers for individuals with developmental disabilities. Those waivers provide in-home care services or other community support services for individuals that have these long-term care needs. A lot of these enrollees also have significant physical health and behavioral health needs. So under Heritage Health, they'll be able to benefit from the advantages of care coordination and having a health plan for their physical health, pharmacy, and behavioral health services. In addition, individuals that live in institutional settings like nursing homes or intermediate care facilities for people with developmental disabilities, those institutional level of care clients will also be in Heritage Health. So while all of those individuals are new to managed care and they will have their benefits coordinated through their Heritage Health plan, their actual long-term support services, those actual in-home services or residential services, will continue to be authorized and paid as they are today. So the Heritage Health plans initially are only taking over the responsibility for the hospital, doctor's office, pharmacy, and community behavioral health services. Some of the key features that you'll see in the contracts is a greater focus on quality, care management, and introducing the concept of social determinants of health into the health plan's responsibility. We have formalized structures to have cross-divisional partnerships for managing the program and working with the health plans. Performance metrics that are specific to our Medicaid members that are identified in the contract and can be updated with the impact of our quality committee, which met for the first time this past week and will continue to meet quarterly. A bigger onus on the health plans to help identify those early needs for care management through those health risk assessments. And then making sure that they are not just looking at the healthcare needs or behavioral health needs of the individuals, rather they are utilizing that overall health risk assessment strategy and care management strategy and identifying individuals who have other social needs. So whether that's food security or housing needs, we can help connect those individuals into other community and state resources that are available to assist them. Common sense as well as strong data suggests that an individual who's chronically homeless and diabetic is going to have a harder time managing their diabetes and is going to spend more time in the emergency room than someone who's not. If you're worried about where you're going to sleep tonight, it's difficult to manage your blood sugar. So really trying to help identify those needs, what those needs are, and address them so that the individual, their health plan, and their provider can focus on their specific health care needs. There are requirements in the contracts for developing and building provider networks that meet geographic time and distance standards based on where the member lives for all the different types of providers, hospitals, specialists, primary care physicians, pharmacies, behavioral health providers, as well as substance abuse disorder and allied health providers. So lots of focus on primary and preventative care, making sure everyone has an assigned primary care physician. One of the ways we want to begin to measure is, can people actually connect with those providers? Are they accepting patients? Are they able to schedule an appointment? So those metrics are all included as well. And then continuing that focus on the health plans, helping providers develop patient-centered medical homes and meeting those criteria. Accountability is a big theme throughout Heritage Health. We have strong contracts at the foundation that clearly set out what our expectations are and what our performance standards are. And then we want to make sure we have policies and procedures in place to really hold them accountable. So all of their policies and procedures have to be reviewed and approved by us. We have numerous reporting requirements on both operational and outcome performance metrics for everything from their call center performance time, their claim processing timeliness, to those actual outcomes and HEDIS metrics. Plans are required to give us full access to all of their systems and information. We will be conducting periodic operational and readiness reviews prior and after we go live. There are also financial incentives, sanctions, and penalties built into the contracts and tied to their performance. They have to deposit 1.5% of their total revenues into a reinvestment account that they have to earn by meeting certain quality metrics. There are financial sanctions and intermediate sanctions in place. If they don't meet certain contractual responsibilities, then those quality metrics that are tied to performance standards will be revisited annually with the input of our quality committee. We also want to make sure that we're supporting our providers. Managed care is not always fun for healthcare providers, and admittedly, we're adding additional layers of administrative complexity to this system. Under the traditional fee-for-service model, you've only got one entity to bill, which is the state. So health plans do add that additional layer. But those plans are making sure that there's proper concurrent review, utilization management, accurate billing, and ensuring that providers are credentialed properly. So while we recognize those challenges, we do think there's value in creating those layers. But we also want to make sure that there are not layers of administrative complexity that don't add value to the system. So we have contractual requirements, making sure they have timely processing, timely payments, timely credentialing, application processing. So there are standards that are all set there. We're also going to require that they continue to follow our state preferred drug list. Even though they're managing the pharmacy benefit, they will have to follow our PDL so that prescribers won't have to navigate multiple different preferred drug lists to figure out which specific drug they should prescribe for a member depending on which health plan they are enrolled in. There are a lot of requirements for the plans to engage in provider training and making sure providers are ready to bill in their systems and that they understand their policies and their procedures. Having dedicated provider support staff available in our state on the ground, ready to assist providers, and that they also individually have provider advisory committees with Nebraska providers to meet regularly and provide input about operational issues and a provider complaint system. We also have an administrative simplification committee that meets regularly with state staff, health plans, and providers to focus specifically on these issues and continuously identify opportunities where maybe we can create some consistent policies across the health plans, consistent health forms, or other areas where we can knock out any administrative complexity that's not adding value. So speaking of value, we really wanted to focus on value within these contracts. One of the ways that we're trying to tackle that is that the plans are required at certain points in their contract to have certain percentages of their provider network in value-based contracts. And what that means is their contracts with the provider to provide services for the members, they have to have some element of quality outcome or cost metrics that they are then engaged with the health plan and meeting. And then there are those financial incentives to meet those, whether that's performance payment, shared savings methodology, or subcapitation, which is when they actually pay the providers a fixed monthly rate, managing their patient populations while taking on some risk as well. There's multiple different ways that the plans and providers can enter into these types of arrangements, but we didn't want to be terribly prescriptive because we want plans and providers to determine what works best for them and what works for their type of practice. For example, you may begin with upside-only shared savings, where the provider only gains if they save money but doesn't necessarily lose if they don't, and then evolve over time to a true shared savings and loss where they take on some risk. There's multiple ways they can tackle that, but we wanted providers to be engaged and have the same incentives as the health plans to manage care, create better outcomes, and to lower cost. So under the current system, you've got this constant tension between the payer and the provider where one makes money while the other loses money, and we wanted to try and ease and reduce some of that tension that exists. A big focus, obviously, for us is on our members. They're at the heart of the program, what the program is about, and it wouldn't exist without them. So we've got to make sure that there are strong protections in place for actually engaging them in the program. Making sure the health plans are providing them with timely and accurate information that's accessible. It's at the right level with the correct information in it, that they have a toll-free call center, that they're meeting those performance standards, that their grievance process is extensive, it's approved by us, ensuring they'll always have access to the state fair hearing process as a step beyond those MCO appeals, and that they do member surveys using national standards. The CAP survey, which is a National Health Plan recognized survey process, which we can measure objectively kind of what the member experience looks like by health plan. And then member choice. We want to make sure that the members are engaged in choosing their health plans now, and that during the open enrollment period, if they're not satisfied, they can choose a different health plan. So one of the ways we're doing that is by expanding our enrollment broker capabilities. Our enrollment broker will be assisting us assisting the members with their choice to find that plan that best fits their needs. We want the members to select their plan, to have their voice in that care. When absolutely necessary, if the member is unable to choose a plan, then the enrollment broker would have the responsibility of auto-assigning members to the plan that best fits their individual needs. We want to support our partners across the division and other state programs as well. There are clear requirements in the Heritage Health plans to have liaisons and coordinate with sister DHHS divisions to have them participate in our committees. Behavioral health and developmental disabilities. Children and Family Services will be involved for the youth that are in foster care, as those youth that are in the system will be receiving services through Heritage Health, and bringing various representatives together will give us better alignment and coordination. This expands beyond DHHS as well. There's the Department of Education, Office of Probation, other community and local agencies. We want to bring everyone to the table and have expectations that the health plans are communicating and coordinating with. And then, like I said, we want to make sure we have a smooth transition. The plans will have to submit to us for approval their transition and implementation plans. We're currently 1 month into our 9-month collaborative implementation period. So there are key staffing requirements that are in place throughout this time period, specifying which roles need to be filled to ensure the presence throughout the time frame leading up to 2017. Additionally, they have to have their network in place 3 months before we go live to make sure that we'll be able to assess if they're meeting our network requirements and that their members are prepared to transition to those providers by January 1st of 2017. There are also continuity of care provisions that require that any services that have been pre-authorized for a certain period of time after the contract starts will have to be authorized even if it's out of network for a certain period after we go live. I briefly mentioned our enrollment broker. We've contracted with automated health systems to provide this service. A key principle for Heritage Health is member choice. So AHS will provide member outreach and support during the open enrollment period to help individuals determine which health plan best meets their needs. Their contact includes letters alerting the members of the open enrollment period, phone calls to provide any necessary counseling as they review their options, and searchable databases for primary care providers. We want to make sure that we have regular communication about what's happening and what's going on. So we've created the Heritage Health branding to help create a unified picture of what the program looks like. We've launched web pages where you can go and learn more about Heritage Health. There are links to the procurement materials, the RFP, and the contracts. Our presentation materials and handouts will all be posted there, including this PowerPoint. We've also posted an FAQ that's being continually updated throughout this process, and we have a link where additional questions can be submitted to our subject matter experts. The clock is ticking down to 2017, and we have a lot of information to broadcast about Heritage Health. So we're taking proactive steps in communications to ensure that we have significant stakeholder involvement as we move forward. So where are we today? This is a broad overview of what the timeline looks like at this point. And as I mentioned before, we're in the midst of the implementation process. Our committees for quality management, behavioral health integration, and administrative simplification have all had their kickoff meetings and are now in full swing. The committee meetings are part of the Nebraska Public Meeting Calendar with agendas and meeting materials provided on our website. So we're looking ahead to our readiness reviews, actively planning the open enrollment approach with AHS, and keeping our sights set on that go-live date of January 1. Again, I just want to emphasize that our focus is on unity. We know that we're better together, so each of the divisions within the department are present at the table. We're collaborating to work together on this. Even though it's a Medicaid program with Medicaid contracts, the entire agency touches base with these same clients across different programs. So at the heart of it, we're all trying to work together to deliver better services for people and deliver better value for the taxpayers. So we want to make sure that we have good communication as we move forward with Heritage Health. The webpage for Heritage Health is being updated regularly, and any questions about Heritage Health can be submitted through a link on that webpage or directly through email, which is dhhs.heritagehealth@nebraska.gov. So I'd like to thank all of you for your time today and encourage you to subscribe to our webpage for updates and email our office with any of your questions. And at this point, we will welcome Nebraska Total Care to share information with you as it relates to their plan.
Thank you, Carmen. Thank you, Calder, and all other participants on the call. My name is Nancy Davis. I am Vice President over Contracting and Network Development. Basically, in the outline, I'm going to cover a few things over just our company overview, the contracting and credentialing process, provider relations, some website and some secure portal tools that we have used for providers, medical management, utilization management, and then leave time for questions as well. So just to give you an overview of Nebraska Total Care as a whole, We're a managed care company that provides health insurance for different types of eligible members, TANF, CHIP, ABD, dual and non-dual. We have a local presence now after being awarded the contract, but our parent company is Centene Corporation based in St. Louis, Missouri. They've been around for about 32 years, and our main focus is the Medicaid population and the underserved. We will, of course, with this contract, be providing statewide coverage in all 93 counties. And our plan is to have over 200 employees located in Nebraska, with our main location being in Omaha, where the call center will be located, Lincoln, and then an office off-site in Scottsbluff as well. At a minimum, Nebraska Total Care will cover the core benefits and services that are in the contract with DHHS. Of course, it's subject to benefit coverage limitations and exclusions in our plan coverage guidelines. One thing to note is all out-of-network or non-PAR providers will be required to submit prior authorizations, excluding family planning, ER, and tabletop x-ray. And that prior authorization list is in the works and will soon be coming. We do have a unique tool on our website called, it's basically a pre-auth required tool where you can actually put in the code number and it will let you know if, in fact, that needs to be pre-authorized and what details we need. I won't go through each of these bullets, but basically to kind of give you an idea of Nebraska Total Care's goals, and this is actually in every state that we go into, the entire goal is to provide the highest level of wellness for those members that choose us as their health plan, improving their quality of life, and then impacting them and improving their health through clinical results that are positive as well. This, as Carmen was alluding to, we're actually integrating behavioral health and physical health in pharmacy, and that's actually probably, if you ask, the best way to get and achieve optimum health. Coordination of care, we do by assisting members with locating a provider. We have some more details on that later on in our presentation. We also coordinate out-of-network providers, determining access issues. If there's not a provider in the member's area, we will work to find out who will be able to provide those services to that member and coordinate accordingly. For continuity of care, we basically have ongoing relationships with our patients and providers, and we'll talk about some unique staffing that we have around that. It basically builds a foundation to make sure that there's continuity among clinical management for each of our members. So on to contracting and credentialing. So we did have an approved contract and credentialing packet that was approved by DHHS. At that time, we used the state listing of any Nebraska Medicaid provider. And inside that packet, we had a welcome letter, basically an introduction of who we are, and a little bit of information about the start of Heritage Health. We had the participating provider agreement, a few marketing pieces, and then a provider data form. This data form is basically just captures data that maybe we have to report on or that would be helpful for our members when they're looking at our website to try to choose a provider or find one near them, and also a disclosure of ownership form. Our theory behind our contracting and our development of the network for Nebraska Total Care is basically any willing provider. We want a robust network with the best possible access. And a lot of times that means finding out what other unique resources there are in the community. It might go beyond your typical provider. And inside basically those agreements that went out, we have our standard language. We also have the state mandated language that's required, and then the appropriate rate exhibit for that provider type. So I would say when I think about different things that, you could possibly see is just confirming that the rate exhibit is appropriate for the provider type that you are. The delegated credentialing agreement is another item that we offer. There are a lot of health systems that choose to be delegated or large provider groups, and we follow NCQA guidelines for that delegated credentialing agreement. So that is something that could be a potential component of the actual agreement, so it's not a separate agreement. As far as the contracting is concerned, we try to, Carmen had mentioned the Administrative Simplification Committee, and one of the things that keeps coming up is, the credentialing is something that is always a struggle, it seems. But CAQH is the Council on Affordable Quality Healthcare. They're an alliance that basically was created to streamline the paperwork for any healthcare provider. So I would encourage you, if you're not participating in CAQH, to go online, and I've provided the link for any new providers, or if you need help at all, maybe if you're already part of CAQH, there's a link or a phone number that you can reach out to them. But basically, you upload all of your information, all of your details, and I think I have on one of the next slides where I talk about the different things. So again, we do accept CAQH. It's actually our preference. If you're already participating, you simply need to go online, log into your account, and attest that basically all your information is current. If there are any documents that have been that have expired, just make sure that those documents are current and uploaded appropriately, and that has to be within the last 6 months. So this is a slide that basically identifies these are the documents that CAQH stores for a practitioner. So at the practitioner level, this just kind of lists and gives you an idea of what those documents look like. If there's a provider that isn't part of CAQH and they're not interested, then we do have a standard provider application that they can complete, but then we would also need copies of the most current documents that are listed there. And this next slide is basically all those credentialing elements for an organization or a facility. So the same rule applies. This is the contact information right now. So anything related to contracting and credentialing with Nebraska Total Care, there's a toll-free number. If you prefer email, you can email networkmanagement@nebraskatotalcare.com. And there's also a fax number should you choose. So this is something, this is the way to contact us if you just have general questions about the process. This is also the contact information should you already have your information completed and you want to send it in. You can send it in by fax or through our email address that's posted. Okay, on to provider relations. We are developing our member provider services department. The provider relations staff is the staff that will be training the providers. So aside from these seminars that are set up by the state, we are hiring provider relations staff to assist us out in the field for one-on-one provider training as it's requested, or town hall meetings, whatever the forum needs to be. For provider relations, the things that they can assist with is your current credentialing or network status, claims issues. If you're part of a group and you need assistance with adding or deleting physicians, they can assist with things like that. So I just wanted to point out that this phone number that's listed for member and provider services, that is the number, but it is not actually functioning yet, but it will be active in due time. So in the meantime, for providers to do outreach, it's that same 1-800 number listed for the credentialing and contact information. Okay. When we look for our provider relations staff, these are the things that they will be reviewing with our provider, our contracted providers that are in our network. Just for education, talk about HEDIS care gaps, and later on there will be a little bit of a look at our secure provider portal tool. They'll assist them with that. Any kind of administrative policies, getting credentialed providers that are new to your office on board with us, anything that needs clarified in the contract. So any types of questions on the roster, which is also something that's available on our portal. So anything related to being part of our network to ease your administrative burden, that's exactly what their purpose is supposed to be. Okay. And right now I'm going to turn it over to Michelle Brochu, who is our Senior Director for Behavioral Health Contracting. We work closely together since this is an integrated plan. So I'm going to turn it over to her, and she's going to speak on our website and secure portal tools and some of the functions within it. it doesn't sound like Michelle is on. I know she is online, so she may be having difficulty on the phone line itself. So I will go ahead and cover this portion unless
she can try and hit *6 to see if her line is manually muted, and she would be able to unmute it that way.
Sure. Michelle, you want to try that?
Okay, go ahead.
All right, thank you. So for the sake of time, I'll go ahead and cover this portion of our web-based tool. Our public site is nebraskatotalcare.com, and on this public site, you can pull things such as provider information for covered services, the provider manual and billing manual, which of course a lot of these things are not out there currently because they have to be approved by DHHS, and we're still in the process of developing a lot of these forms. Prior authorization code checker, which is the thing that I mentioned before, where providers can put in an actual code and find out if a prior auth is required or not. Some of the prior auth forms, notification of pregnancy forms, other various operational items can be pulled down directly from our public site. Plan news, newsletters, announcements, that sort of thing. Typically, those are put out by our marketing department. It has different articles that relate to maybe what's going on with the state, some frequently asked questions that are going on with the program itself, and also find a provider. So that is basically, you'll hear it shortened as FAP, and that is where members or providers can go to find a provider that's local. If you want it for referral purposes or other reasons, you can go on directly and do searches by zip code, county, city, etc. And again, this is the provider services number listed. That is the exact number we'll have, but it's not yet functional. So if you have any questions around that, just call the other 800 number around contracting and credentialing, and they can assist. Okay. So this is just a screenshot of our secure provider portal. Providers can go online to check member eligibility. Their patient rosters are listed. It's a great way to stay up on the current health records or any care gaps for your members. Authorizations, you can submit claims directly through our provider portal. You can also correct claims and make adjustments directly online with us as well. Your patient's history that happens to be a Nebraska Total Care member can also be pulled online, and also PCP cost reports on a monthly basis. It is free to register, and you basically register by your tax ID number. Okay. And again, this is just to kind of point out some of the various items that can be pulled from our web portal, and not just viewed, but you can also pull them down in a report format, either in PDF or Excel. Your patient listing that's going to show their care gaps, ER utilization, pharmacy claims report, or any high cost claims can be pulled down in a report format. Okay, and for the medical management piece, I'm going to turn it over to, and I think Jenny Clark and also Julie Rothiger are kind of going to go back and forth for the next few slides.
Hi, this is Jenny Clark. I don't know if you can hear me or not.
Yeah. Yeah, Jenny, we can hear you fine.
Okay, good afternoon. From the medical management components and team, it consists of our utilization management department, which includes prior authorizations and concurrent review, as well as our member connections, which is a team of staff who are locally within the communities, boots on the ground, who support our medical management team in helping us locate our high-risk members, and they're very community engaged, where they share a lot of education, Start Smart for Baby programs, and other programs that help this population and other programs. We have our quality management team, and then member education, where we work closely with our disease management programs and our care gaps. For the utilization management team specifically, this is where the prior authorization requests and activities occur. We accept prior auth requests and either telephonically, by fax, and the easiest and preferred method would be the provider portal, where you are going to our website and it's secure and it allows you to actually go in and you can determine if a procedure, outpatient, inpatient, tests, and other inquiries require prioritization or not. And we do utilize, obviously, our behavioral and clinical criteria to help determine and manage any prior authorizations. There will be more information posted as well within our trainings to help advise and guide you on your authorizations.
And we're going to have a question and answer period at 7:30, so we can move on to UnitedHealthcare Community Plan of Nebraska.
This is Kim Manning. I'm the Director for Marketing and Community Outreach. Carmen, right now our slides are kind of backwards. Can you hear me?
We'll get it fixed for you. Just a second.
As we're waiting for the slide deck to be corrected, the outline for which we're going to cover tonight is around an introduction of the health plan. We'll get into credentialing and contracting, followed by service authorization, claims and appeals, and then provider resources. I'm going to continue to present in terms of time. We could go to the next slide. Next one. So our brief overview on UHC is really giving us an opportunity every day to make a positive difference in the lives of the individuals we serve. So our mission, helping people live healthier lives, is truly part of the integration of physical health, behavioral health, and pharmacy, in which it allows for us to care for the members through a person-centered approach. And as you look at our vision statement, I think the simple way of stating it is we are focused on building a stronger culture of service excellence for providers, our members, and our state partners. Next. At UnitedHealthcare, we have a very focused culture, integrity, truly making an honest commitment and consistently honoring those commitments to our providers and to our members. When we talk about compassion, walking in the shoes of the people we serve, we must be truly compassionate and genuinely understand, feel, and identify what our members and our members' needs are and make action upon those needs. Through relationships it builds trust in order to take action and find solutions, and trust must be earned. For innovation, we truly look at inventions for the future, learn from the past, to service our providers and members more fairly, productively, and consistently. And then finally, around performance is truly demonstrating excellence in everything we do for our providers and for our members. A couple of facts around Nebraska. UnitedHealthcare has been in our Nebraska community since 1984. We actually cover 428,000 lives in the state, and we have more than 328 employees in the Nebraska market. In terms of the community plan, we have been providing services to members for 20 years, starting within 3 counties and then currently within a 10-county area. And we are very excited to be able to provide services in the 93 counties of the state. And as I complete my conversation with you, we believe that the power of partnerships and collaboration is key to improving the health of our communities. So thank you for your participation and allowing us to present to you tonight. And I will turn the presentation over to my colleague, Jeremy Sand.
Great, thank you, Kim. I will be on slide 8 of our presentation. Again, my name is Jeremy Sand. I'm Director of Provider Network Programs for UnitedHealthcare. So what is credentialing? Credentialing is an industry-standard systematic approach to the collection and verification of a practitioner's professional qualifications. It's based on NCQA standards, the UnitedHealthcare credentialing and re-credentialing plan, as well as criteria that's applicable to the Division of Medicaid and Long-Term Care. The credentialing and re-credentialing plan is accessible via our website, which is UnitedHealthcareOnline.com, and you can go out and open that up to review that at any time. Next slide is how to begin initiating credentialing for UnitedHealthcare Community Plan. You can begin by calling our automated service line at 1-877-842-3210. Please be ready to provide your tax identification number as well as your Social Security number. You want to follow the prompts of healthcare professional services, followed by credentialing and then requesting for participation. UnitedHealthcare also utilizes Council for Affordable Care, Quality Healthcare, which is a data collection of your credentialing requirements. If you've got questions or need help, you can visit caqh.org, or you can also call the email or the website address there or the phone number. If you have any credentialing questions around medical, we've given the number at 1-877-842-3210, or you can go online. For behavioral health credentialing questions, we've listed the number at 1-877-614-0484 and listed a web address for you to seek additional information. And then for pharmacy credentialing, we've also listed a assistance line number for you, which is 1-800-613-3591, as well as a website and email address for you. Next slide. So the process of completing the application is that the provider would go out to CAQH, the Universal Provider Data Source, and update your credentialing information. You would initiate the credentialing with UnitedHealthcare, and our credentialing specialist will provide you with a CAQH ID number. You will use that CAQH ID number to grant UHC access to review your information through CAQH. The entire application must be completed prior to our primary source verification, and CAQH enables your credentialing data to be used by multiple health insurance companies through a streamlined process. If you do need a paper credentialing form, we can send that out, and we do have the ability to credential you through a form. Next slide. So the next steps to the credentialing process is we go through primary source verification. Once we have verified your credentials, we will forward that to committee review, reviewed by peers of your practitioner type. Once approved, we will send notification giving you the credentialing committee's determination and the effective date of your credentialing status. We also require you to be having contracts that are signed, and that'll go on the next slide. Once your contracts are signed, we will load you, and then keep in mind that re-credentialing is also required every 3 years. Next slide. So following the credentialing process, we also require you to contract and execute a contract paper with United. Now, with the new Heritage Health Program rolling out 1/1 of 2017, we are not requiring our providers to go out and do new contracts. We've been in the market for over 20 years, and we have existing agreements in place, and we are continuing to contract with those providers that are enrolled with Medicaid that have not contracted with us, but if you have already contracted with us, your contract remains intact. So if you have questions around medical contracting, you may call 1-866-331-2243 or contact our team mailbox that's listed there. For behavioral health contracting questions, you may contact 1-877-614-0484 or contact the team mailbox that we've listed in the presentation. And then finally, with pharmacy provider contracting questions, you may call 613-3591 or email our pharmacy contracting team email. Next slide. UnitedHealthcare also conducts delegated credentialing. Delegated credentialing is delegating those credentialing functions to another entity. The requirements that we go through for delegated credentialing is a pre-assessment of the delegated entity, which ensures that they're able to meet our credentialing standards. We also require a credentialing delegation agreement to be in place with that health system. We go through an annual evaluations to ensure that the provider is compliant with our credentialing standards. We go through ongoing oversight and reviewing of those credentialing reports to make sure those providers that are credentialed are meeting the credentialing standards. And then if there's any follow-up required, we require our delegated credentialing entities to make those corrections. Again, network participation agreement is required. Next slide. So pharmacy credentialing is a little bit different. Independent pharmacies begin the process with submitting a credentialing application. It will include the disclosure of ownership as well as any credentialing applicable information. The credentialing application is, packets are sent out together with instructions to be completed by the pharmacy, and it's credentialed pursuant to our administrator credentialing policy. The applications are reviewed to verify proof of the pharmacy's credentials, which may include valid state licenses, ownership and affiliations, or recent inspection dates by the Board of Pharmacy. Next slide. Our pharmacy credentialing also reviews to ensure compliance with professional standards as well. We review the adequate hours of operation or making sure that the pharmacy is compliant with the drug utilization review and plan design parameters. The turnaround time for completion is approximately 7 business days, and again, re-credentialing for pharmacies is required at least every 3 years. We do have delegated credentialing with our chain pharmacies as well as our pharmacy service administrative organizations, and those we delegate and make sure that they are maintaining to our credentialing policies and have a credentialing program for themselves. If you have any questions around pharmacy credentialing, you may call 1-800-613-3591 or email to the address that's listed in the presentation. Lastly, for credentialing, we provided a helpful hint for a complete and clean application. So after you've uploaded your information into CAQH, you want to make sure that you've included the professional liability insurance fact sheet. You want to make sure that you've included the name, NPI, and hospital privileges of the practitioner, as well as a copy of the current DEA certificate or the name and the NPI of the practitioner who will write prescriptions. You want to make sure that you have granted UHC access to review your CAQ application. For credentialing timeframes, again, we're required to get those completed within 30 days. If you're looking for a status update, you may call 1-877-842-3210 to get an update on your credentialing application. And lastly, around disclosure of ownership forms are required. You need to make sure that you have submitted your Social Security number as well as your date of birth, and disclosure of ownership forms are required for the practice, the practitioner, as well as any managing employees. I'd like to thank you for partnering with us and partnering in our network. I'd like to turn this part of the presentation over to Barb Palmer and Adam Proctor.
Thank you, Jeremy. I'd like to share with everyone some prior authorization requirements. Prior authorizations may be required to meet state or internal UnitedHealthcare requirements, but not all services require a prior authorization. Notification of a requested service is not a guarantee of a payment. The care provider or facility requesting the prior authorization will receive a written decision of the clinical coverage based upon medical necessity. If the authorization is required, clinical coverage will be reviewed and determine if the service does meet medical necessity based upon evidence-based clinical guidelines. After the review is completed, if the clinical information submitted does not meet the medical necessity for guidelines We do offer a peer-to-peer review for the provider, and additional information can be submitted at that particular time. In our next slide, we have a list of our prior authorization, a sample list.
And in the spirit of transparency, this is Adam Proctor, Behavioral Health Clinical Manager, and in the spirit of transparency, we wanted to give a snapshot of some of the items that will require prior authorization as we move to our integrated product, looking at inpatient hospitalization services on the physical health side, as well as the acute and subacute inpatient care for psychiatric services. Also looking at the adult and youth residential substance use and psychiatric services would be ones that would require prior authorization, in addition to durable medical equipment, diagnostic testing, hospitalization, day treatment, intensive outpatient for behavioral health services, psychological testing, electroconvulsive therapy or ECT, transplant services, assertive community treatment or psychiatric crisis stabilization, home health and hospice, as well as prescription services. Now, while this is not an all-inclusive list by any stretch, we wanted to give a good core list of regularly used services that everyone could anticipate having with a prior authorization. Similarly, we have streamlined the process and have one prior authorization phone number in which to request telephonically. We'll also offer our website portal to request prior authorization via the web as well. And you can find our prior authorization listings at uhccommunityplan.com/healthprofessionals.ne.html. And that will continue to be updated and developed as we continue to further build out our prior authorization list. Additionally, for our prescription information, to manage cost-effective prescriptions beginning January 1, we're going to have our PDL posted publicly at our UHC Community Plan site. As was indicated in the earlier part of the presentation, we will be following the state PDL to promote an ease and seamless transition for prescribers out there in the marketplace. And our prescription prior auth information line will be 1-800-310-6826, and you can speak to the provider help desk. Additionally, we offer formularies, prior auth lists, 72-hour emergency drug availability, and provider reference guides at your fingertips all the time on our website. And with that, we'd like to transition the program back to Jeremy.
Great. Thanks, Barb. Thanks, Adam. Next, I'm going to be leading you through our claim submission process and our appeals process. There are 3 different ways that you can submit claims. You can submit them electronically through several clearinghouses that we've listed below. You may also submit claims through our secure portal, which is UnitedHealthcareOnline.com, or you may also submit a paper claim at the mailbox at UnitedHealthcare, P.O. Box 31365, Salt Lake City, Utah, zip code 84131. You want to make sure to include the subscriber's ID number with your claim, as well as the payer ID number 87726 for community plan claims. Next slide. We also want to give our providers the opportunity to be able to enroll with electronic payments and statements. This gives you the ability to receive electronic funds transfers for claim payments, plus your EOBs are delivered online. What this does for you is it lessens the administrative costs, it reduces reimbursement turnaround time, and funds are deposited directly into your bank account. For more information, you can call 866-842-3278, or you can visit UnitedHealthcareOnline.com for more information. Next, on slide 24, is our appeals process. The provider may appeal any decision regarding authorization of provision of services. Appeals can be made by calling or writing our customer service center within 90 calendar days of the date of the notice of action. You can mail that in at the National Appeals and Service Center at P.O. Box 31365, Salt Lake City, Utah, 84131, or you can contact the 81800 number that we've listed there. Expedited appeal decisions can be requested, resulting in a 72-hour turnaround time if there's a risk to the patient's health. Next slide is our claims administrative appeals. These are appeals for any payment decision after healthcare services are rendered, which may include missing prior authorization, untimely filing, or reimbursement disagreements. They can be made by sending an appeal letter to our appeals service center at the address listed there. Claims adjustments for underpayments or overpayments may be simplified in a submission through UnitedHealthcare Online or by calling a provider advocate to request the adjustment. Next, I would like to walk you through some of our provider resources and tools that are available to you. On slide 27 is a list of our online provider resources. Link is our gateway to all of our UnitedHealthcare online tools and resources. Several of you have probably already used this. This replicates a online version of an iPad with several of our applications. You can pull all these tools to be available to you at the single touch, where you'd be able to access UnitedHealthcare Community Plan website, where we will list things such as our administrative guide, reimbursement and clinical policies. You can use Link to access UnitedHealthcare Online, where you can look at submitting a claim or verifying member eligibility or submitting a prior authorization. Next slide. Additionally, we have provider relation service model. They're an important resource for you to be able to answer questions or resolve issues. Our provider relation service representatives are your navigational specialists. They're your product expert. They're externally focused to interact with the provider, and they're also your relationship manager working between the office staff with physicians as well as UnitedHealthcare. Next slide. In addition to provider advocate that are in the market, we also have our call service center. There are various options for you to be able to access information. You can access through UnitedHealthcare Online, which that gives you self-service options that are available 24 hours a day. You may also access our our provider service line, which is 1-866-331-2243, which Adam also said that that will be for all of our integrated products of medical, behavioral, and pharmacy. In addition, you can also talk to a customer care representative there to answer any questions. Lastly, we provided you a contact list with our health plan staff, and we will be available to answer questions after all the presentations have been given. I thank you very much for your attentiveness and for your participation with UnitedHealthcare.
Okay, we're going to pass the mic over to WellCare of Nebraska, but first I wanted to answer one question that someone had posted asking if the PowerPoints will be available, and yes, we're going to have everything available on our website. Our PowerPoint will be there, the 3 PowerPoints from the plans, and the recording from tonight's webinar.
Hi, everyone. My name is Laura Lee Rubel. I am the plan president for WellCare of Nebraska. Before we move into the presentation, I just want to tell you a little bit about WellCare. WellCare is new to Nebraska. However, we are very excited to be here. We are going to also hire roughly 200 associates here in the state, and we plan offices in Omaha, Lincoln, Scottsbluff, Kearney, and Norfolk. We currently are only operating in government health plan space. We serve 3.7 million members across the country. 2.4 million of those are on Medicaid, so we have a great deal of experience serving Medicaid-eligible members. Tonight, I know we want to spend some time specifically on transactional relationship between ourselves and our providers, so we're going to touch base on contracting and credentialing requirements, claim submission, appeals and grievances, and authorizations and care management. Next slide, please. Next slide. So you've already heard quite a bit from our colleagues with the other plans around the contracting and credentialing process, and I don't want to be terribly repetitive, but there are a few things that will be the same across all 3 plans. We have already mailed our contract packets to all Medicaid providers across the state, and these packets include a cover letter, a contract, some information about WellCare since we are new to Nebraska, a provider profile sheet, an IRS Form W-9, and the required Nebraska ownership and controlling interest and conviction disclosure form. There are also instructions in the packet. If you need help completing any of those forms, there are instructions in the package about how to contact somebody for help with completion of the forms. Next slide, please. Again, you've heard a lot about CAQH this evening, and one of the reasons we really want to focus on that is it will simplify the process and make it much more efficient if you are a CAQH provider, participating provider. I think everyone that you've already heard from has spoken to the process and why it's important to have attested to your CAQH profile if you are a CAQH practitioner. I just want to reemphasize that is one of those things that can really slow up the credentialing process if that attestation isn't present. So I hope that if you are a CAQH provider, you'll make every effort to go back and attest to your CAQH profile. Providers who do not participate in CAQH or facilities that need to be credentialed, our credentialing application can be found at the link on the slide. Next page. You've already heard, again, quite a bit about the credentialing process, so I won't belabor those points. I do want to highlight the fact that while our credentialing committee normally meets monthly, as we move towards implementation and preparedness for demonstrating our network adequacy, we will be having credentialing committee meetings weekly. There will be people reviewing our credentialing packets regularly, so we will make sure that these are turned around, and we are required to have them turned around within 30 days by state contract. So this will be a very quick process. Next slide. Providers who are properly credentialed in 2016, your contract effective date isn't until January 1st of 2017 to coincide with the launch of the program. Beyond January 1st, providers who submit their contracts after January 1st of 2017, their effective date will be the first of the following month. Once a provider has been credentialed, they'll receive a letter that tells them about their contract's effective date, and it will also include an executed copy of the contract. Another important point from that letter is they'll receive their WellCare provider identification number and instructions on how to register as a participating provider on our website. That becomes important because when we talk about a secure provider portal, those services, those functions require the participating provider ID number. So when you hear WellCare speak to the secure portal, you have to have that provider ID number in order to use those services. Next slide, please. We've touched on this. I just want a couple of risks to call out. The provider name or group name that is on the contract must match what's on the IRS Form W-9. Sometimes those things can slow down the process if, let's say, we have Dr. Joe Smith, but his W-9 says Joseph Smith. Although it seems intuitive that would be the same person, it really, from a legal perspective, must match exactly. That's often something that slows down the credentialing process. And we've talked through the CAQH requirements. Also related to the ownership, controlling interest, and conviction disclosure form, WellCare will accept the form that is already on file with Nebraska Medicaid in lieu of having to do a new form, because that is already a requirement of Nebraska Medicaid. Next slide, please. Briefly covering our claim submission timeframes, claims must be submitted within 180 days of the date of service. Claims will be processed and paid or denied within 15 business days of receipt. We do have daily check runs for both paper checks and electronic funds transfers, except for Sundays and the last day of each month. But other than that, it's daily. Next slide, please. We, too, have 3 different methods for you to utilize claim submission. We can accept them through EDI, electronic data interchange. We can accept the direct data entry through our secure portal, and there's the address there for paper claims on the presentation. Information related to provider appeals. Providers may request an appeal regarding payment or contractual issues on their own behalf within 90 days from the original date of utilization management notice of action or claim denial. Cases filed after the 90 calendar days will not be reviewed if they will be denied for untimely filing. If the provider feels they have filed their case within the appropriate time frame, the provider can submit documentation that they did, in fact, submit it within proof of timely filing. When submitting an appeal, provider must supply specific documentation, include all medical records related to that service, or if it's related to a claims payment issue, any supporting documentation that would support the grounds for reconsideration. Next slide, please. From a utilization management perspective, we follow many of the same processes that you've already heard about tonight. A few things I wanted to call out. The submission of requests for prior authorization can come in 3 ways, by fax, by telephone, or via the secure provider portal. We will turn those around as quickly as possible. Again, expedited requests will not exceed 72 hours. If the patient's health is at risk, there will be notice given as expeditiously as possible related to the member's condition. Next slide, please. This is related to retrospective review. We do review post-service requests for authorizations of inpatient admissions or outpatient services when there are retro eligibility instances. So if someone becomes retroactively eligible for Medicaid and is enrolled with WellCare of Nebraska, services are rendered in that time period, we will retrospectively review the authorization request. Those requests can be initiated by the provider, or we may do it if the retro eligibility information is made available to us. Those can take up to 30 days to make a determination. Next slide, please. A couple of resources I wanted to call to your attention on our website. This is on the public website, not the secured website. The first 2 are our clinical coverage guidelines. It's a search tool that helps you determine if it's a covered benefit or not. And it's based on evidence that using the benefits that are prescribed by Medicaid and also the guidelines around medical necessity for certain procedures or new technologies that's found in our clinical coverage guidelines. Our clinical practice guidelines, our CPGs, are those best practice recommendations based on available clinical outcome trend and scientific evidence. In other words, those help you understand what criteria we're using to review authorization requests. The last one, we also have an authorization lookup tool, which is a very easy way to not only verify the authorization requirement by code, but by place of service. Next slide, please. So here's a screenshot of that authorization lookup tool. It also there's a companion document. If you see at the bottom of that screenshot, the quick reference guide, there is a more detailed document that will give you an overview of different services, different points of contact, all of our mailing addresses that you might need for submitting an appeal. The quick reference guide is a wonderful resource that's updated regularly and makes it very easy for providers to find quick information about transactions with us. If you go to the next slide, I wanted to show you a sample of what happens with the authorization lookup. You enter simple CPT code, and it will come back and tell you from the place of service, because sometimes that's the variable. If it's in an office setting or outpatient hospital setting or ambulatory surgery or other settings, it will tell you whether an authorization is required. Next slide, please. For questions or to request a contract packet, there's an email address, networkexpansion@wellcare.com, and you have the phone numbers there. I'm standing in tonight for our local contact, Tracy Smith, our Senior Director of Network Management. Tracy is actually with providers in another part of the state, so thank you, Tracy. But there is her direct email and direct contact information. So you're welcome to use any of those resources for questions or more support. And I really thank you for your time. Thank you for having us here this evening, and I'll turn it back over to the state.
All right, thank you to all of the plans for sharing your information with us. Now, as we go ahead and move into the question and answer portion, if you could possibly identify who your question is directed to, if you could put that you have a plan question or a question for the state, it will help us to make sure that we are answering those correctly.
And we will be reading the questions that we are submitted. We've received questions in a few different ways on the webinar, through the chat, through the Q&A for all to see, and then through the Q&A directly to the moderator. We'll go through those, but from now on, if you could submit your question through the Q&A box, that'll help us to make sure that we're getting them all. So we'll begin with the questions that we received directly in the chat. And we've already answered the one regarding the PowerPoints being available on the website. The next question was, what should we do if we have not received our packet from WellCare? I'll answer generally that all the plans have provided contact information for requesting a provider packet, and that information is on the slides. But Laura Lee, do you want to respond specifically to WellCare?
Sure. We have sent out packets. We've leveraged the state's Medicaid provider distribution list. However, if we missed you somehow, all you need to do is send an email to that network expansion at wellcare.com, and we'll get one out to you immediately.
Great, thank you. The next question is directed to UnitedHealthcare. Will UHC accept Relay Health for a clearinghouse for submitting electronic claims? UHC?
Yeah, this is Jeremy with UnitedHealthcare. I don't know that off the top of my hand, but I would be gladly to take the provider's information and follow up with them directly.
Okay, we can follow up with you with that information. The next question is, what happens if the plans do not meet their minimal requirements for signed contracts by our deadline? This is Calder Lynch from the state. We've already begun working on the readiness review process to ensure that the plans are prepared to go live and meet the state requirements. They are already begun submitting policies and procedures to us, and we'll begin desk audits of those in the coming weeks and months. We will be assessing each plan individually for readiness as well as the program overall. And we will go live on January 1st only if we are ready. At this point, we're feeling very good about that, given our timelines and the work plan that we have ahead of us. But we'll be communicating to providers and the public if there are any concerns regarding go live and if that date changes. But at this point, we're full systems go for January 1st. The next question is, WellCare provided timely filing. What are the timely filing requirements for the other two plans? Can we start with you, Nebraska Total Care?
Yes, this is Nancy Davis, and it is 180 days.
Thank you. And UnitedHealthcare?
Yeah, for UnitedHealthcare, it's based on the contract that you have for timely filing.
Can you clarify, is that the contract with the individual provider?
Yeah, so it is with our individual contract with that provider. Standard is within 120 days.
Thank you. The next question is, when will provider enrollment be closed for plans participating in Heritage Health? I'll start by answering from the state's perspective. Plans are actively enrolling providers now. There is not a deadline per se. However, if you would like to begin treating members on January 1st, you'll need to be enrolled and credentialed prior to that date. However, I will say one key date will be to be enrolled in the provider before individuals begin enrolled in the health plan, prior to individuals beginning to choose their health plan and enroll in their health plans, because that enrollment process will take into account the providers that are contracted with that plan, and if that member's PCP or other provider is contracted with that plan, and health plan enrollment will begin in September. So it will be important that if you want your provider status with that plan to be taken into account during enrollment, that you be enrolled with that health plan been and credentialed and contracted prior to that September go live, and then more importantly prior to the auto assignment of members in December and the go live in January, but it will be an ongoing process. The next question is, we have emailed the network expansion email twice for credentialing application packet. Do we need to resend? And that was directed to WellCare. Laura Lee?
I'm disappointed to hear that they've asked twice. If you could provide me that, if I could have the name of that provider, I'll make sure one gets out tomorrow.
We will do that. We will share that with you.
Okay, thank you.
And to that provider, if you could just share your contact information directly to us, we will get that to WellCare through the chat function. The next question is, why does UHC not have to meet the state guideline of 180 days for timely filing? I'm going to say we're going to take that question offline and have some further discussion internally, and we'll provide some further clarification and guidance after this webinar. Next question is, please clarify, do providers enroll with only one plan? Providers have the option of contracting with as many of the 3 plans as they would like to. We would certainly encourage providers to contract with as many or all the plans to encourage broad networks for member participation. But in order to serve a client that's enrolled in a health plan, you will have to be contracted with that health plan. So if you have members that choose all 3 plans, or if you have patients that in your patient panel choose all 3 plans, if you want to continue serving all of those patients, you'll have to contract with all 3 plans, as you'll only be able to serve those whose plans you're contracted with. The next question, moving to our Q&A function, are all 3 Medicaid contractors familiar with home health rules and regulations and with how home health works? I will say that we have, the plans all have copies, and we have shared with them the state regulations. They were part of the RFP, and we've shared with them that information. We're also conducting bi-weekly implementation meetings with the plans, where we are bringing in subject matter experts from across the division to inform the plans regarding our rules and regulations. We will ensure that home health is a focus of one of those discussions. The next question, will UHC, this question is directed to UHC. Will UHC credentialing still use Optum for credentialing? The current process does not follow the intent of CAQH. I receive weekly requests from UHC Community Plan to have providers re-answer the CAQH disclosure question and re-sign a paper release. UHC, can you address that?
Yeah, so the question was around Optum. Was that Optum Behavioral or Optum Pharmacy?
It does not, the question is not specific, but can you address both?
Yeah, so for UnitedHealthcare Community Plan, we're integrated from a United Health Group perspective. All of Optum Pharmacy, UnitedHealthcare, and Optum Behavioral is all owned by United Health Group, and we're working to integrate across all of our different divisions. If you are credentialed with Optum, you will be credentialed with UnitedHealthcare Community Plan. You know, and if there are some issues that you're having with credentialing, we would be happy to take your information and follow up.
Thank you. The next question would reply to all 3 of the MCOs. The question is, I am a Medicaid provider presently under supervision of another Medicaid provider in an agency. Would the provider enrollment packet have been sent to my agency? I have not received anything from any of the 3 MCOs as of yet. Can we start with Nebraska Total Care in answering that question?
Yes, this is Nancy Davis again. We basically mailed out, in order to not send multiple packets to the same location, we did it by tax ID number. So that's how we did it, 1 per facility.
UHC?
Yeah, we will follow up with provider packets if we need to get that out to you. Just give us your contact information, or you can also contact the information that we listed in the presentation, and we'll follow.
Can you comment on how your provider packets were mailed out? Were they done similarly in terms of one per facility?
Yeah, what I said in the presentation was that if you're already contracted with UnitedHealthcare,
Gotcha.
that you're already contracted, and you would not need to have a contracting packet sent out.
And WellCare?
We also leverage the individual tax identification numbers and sent one packet per 10, but if we need to send additional, we certainly can.
Thank you. The next question would apply to all three plans and maybe something we need to take offline and do some further discussion. The question is, will providers be able to continue providing telehealth through breakthrough and obtain reimbursement? Are any of the plans familiar with this, or do we need to do some further research?
I'd like to ask that we do a little further research. We certainly want to promote and support telehealth. I'd like to learn more about this provider.
This is Adam with UHC, and I believe that Breakthrough is Magellan's current behavioral health telehealth platform that they utilize. So I think we would need to look at what the platform of the specific plan would be moving forward with Heritage Health.
And this is Nancy with WellCare. Yeah, I would say the same as WellCare. I'd like to get more information on it, but we definitely would want to support if it's something that we can.
Thank you. We will get more information on that and share with the plans and take that and do some more research to provide an answer back, and perhaps discussion in our Behavioral Health Integration Advisory Committee. So thank you for providing that. The next question is, will your MCOs use subcontracts for any services, particularly for behavioral health? If so, how do you plan to integrate care management, and will the claims be sent to different addresses? I'll start from the state's perspective. We did have some specific requirements in the RFP regarding subcontracting, in that subcontracts had to be approved by the state in advance, and requirements around what those must contain. Specifically to behavioral health, we required some pretty extensive integration of those services, integration of systems, integration of care management. All three of our plans that we're contracted with for Heritage Health have a behavioral health plan that's part of their corporate entity, and so is not contracted out to an independent third party, although there may be some nuances in terms of where claims are sent. So I'll let each plan address some of those specifics. And we'll start in reverse order with WellCare.
WellCare does not subcontract our behavioral health services. That all credentialing, contracting, claims payment, utilization management, all services are performed by WellCare.
Thank you. UHC?
Yeah, we will have a single claims platform that we'll be using for our United and Behavioral. Pharmacy, of course, is same-day billing, and those address information will be listed online.
And correct me if I'm wrong, but United will use their Optum behavioral plan in Nebraska?
Yeah, it's through Optum, and our contracting is through Optum, but we will be using a single claim system for that.
Yeah, and Optum's embedded with the plan here to provide an integrated care management platform with field care advocates, local staff, local recovery and resiliency, all within the care management, person-centered care management model that we'll be using.
Thank you. Nebraska Total Care?
Yes, this is Nancy again, and our behavioral health and physical health are both integrated in the contract, and it uses a single platform for claims processing. And I'm actually going to ask if Jenny or anyone else on the call from Nebraska Total Care can confirm for pharmacy.
Yes, it should be the same for pharmacy as well.
Okay, thank you, Jenny.
So the next question is for all plans. The question is, Magellan today in their current contract does not cover PLMHPs to provide evidence-based services of PCIT and CPP. Do you know if your plans allow PLMHPs to provide these services to members? And again, this may be a question that the plans need to do some research and respond to, but if anybody can respond to it offhand, can you do so now?
This is Adam with UHC, and it is something that I think we'll need to do some research with internally with our clinical team to identify how we're going to move forward with those evidence-based practices. They are part of the benefit plan. We're absolutely committed to continuing to cover CPP and PCIT, and we'll look at the provider requirements to do that moving forward and communicate that out.
Anything from NTC or WellCare on that, or would you like us to take back on that one?
NTC would like a take back, if you don't mind.
Sure.
Same for WellCare.
All right, well, we will follow up on that. Thank you for the question. The next question is, are the 3 Heritage Health Plans required to accept all current Nebraska Medicaid providers? I'll answer from the contract perspective. Nebraska is not generally in any willing provider state in our contracts, in that they're required to contract with any provider that's enrolled in Nebraska Medicaid, with the exception of pharmacies. There is a requirement that they contract with all pharmacies that are participating in the program today. However, each plan can probably speak to their intent in terms of building their initial networks, and I'll let them do so now, starting with NTC.
Yes, thank you, Calder. We are opening up for the most robust network possible, so we will be looking at any willing provider that passes credentialing.
And UHC as an existing plan, can you comment on that as well?
Yep, for all of our pharmacy providers, we have already reached out for contracting purposes. If you are credentialed and contracted through Optum Pharmacy, you are contracted for UnitedHealthcare Community Plan. We have them after reviewing the incoming state file of a list of providers. We're just working now on making those amendments.
And can you speak to the other provider types?
Yeah, so for the other provider types, you know, with our medical, we already have fully statewide network that we have in place today. We're working to continue to review any providers that we don't have contracted to get credentialed and contracted, and the same with our behavioral, working with Optum Behavioral. Any provider that is credentialed and contracted through Optum Behavioral, they're contracted with UnitedHealthcare Community Plan, and we're just making sure that we're updating the appropriate regulatory appendixes as well as the Medicaid program.
And WellCare?
We want to encourage the most broad and easily accessible network possible. So to echo what my colleagues have already said, as long as a provider passes through credentialing and is interested in caring for our members, we would love to have them in our network.
Thank you. And then I'll just close that question by saying we also have specific requirements in their contracts in terms of network adequacy based on their membership. So prior to go live, we'll be doing an examination of their networks to ensure that they meet those requirements, and then requesting, if necessary, corrective action plans if there are gaps that need to be addressed. So for the next question is it possible for the Places for All plans to list all the clearinghouses they accept? This particular provider uses Office Ally. Can each plan speak to if you have a resource available now, or we'll have one that would list all the clearinghouses? And we'll start with WellCare.
We can certainly provide a list of the clearinghouses we work with and the different payer ID numbers. I want to say we already have one, and I can provide that. But if we could gather a list of the clearinghouses that are frequently used here in Nebraska, it might be helpful for us to match those together and see if we have any gaps.
Thank you. UHC?
Yeah, for us, we accept most of the clearinghouses. I think we listed in the presentation: WebMD, Envoy, Medavant, ENS Health. I did get follow-up that we do accept Relay Health, which was a question that we had earlier, and so I wanted to confirm that. For any additional ones, we've listed on our website. We actually have a document that will walk you through how to verify your security in-house through UnitedHealthcare Online, and so I would direct the provider to go there and to look at the EFT process.
NTC? Nebraska Total Care?
Hi, sorry about that. Yes, we accept Envion, SSI, Gateway EDI, Medavant, Availity, and actually if there's one that we come across that we're not currently using, then we can start that process if it's someone that is highly utilized in the state. And they can find more information on our provider portal as well.
Thank you. And we'll take that back to do some surveying to see if there are any other clearinghouses that are in use in Nebraska and share that information with the plan. So thank you very much. The next question is, would it be possible to have one of these webinars focused on the American Indian Tribal Health Departments or Indian Health Services? Yes, we will take that back and look at that opportunity. I know that we are looking at several different opportunities to engage with our tribal partners and those providers. Specifically with these contracts, each plan is required to have a full-time tribal liaison locally on staff, and they'll be meeting with us as well as the tribal facilities and providers to address some of those issues, specifically understanding that there are some unique things that we need to address there. So thank you. We will have some opportunities for those providers. For UHC credentialing, so the next question is directed to UHC. It says for UHC credentialing, when calling the national credentialing request, they tell us 60 to 90 days for credentialing, and that is typical. It was stated there is a 30-day credentialing timeline. Will the current timeline change to 30 days? Before I turn it over to UHC to add to that, I will say each plan is contractually required to provide a response on credentialing applications within 30 days of receipt of a complete application. So UHC?
Yes, that is correct. Our time frame for a clean submission is within 30 days. Like I said on the tip sheet, there are some additional things to make sure that you do to ensure that you get a clean submission.
Thank you. The next question, will there be a published fee schedule rates by procedure code? I'll start by answering that the state does publish its fee schedule, and it's updated, at least annually on our website. Many of the contracts in the plans may reference that fee schedule, and then with the advent of value-based contracts, there could be some deviations in the individual contracts that the plans have with the providers, but they'll often reference the state fee schedule, which is posted on our website. And so that would be probably the best source of that information, and we can certainly provide a link to that on the Heritage Health website. The next question is a clarification from the earlier question about receipt of the provider enrollment packets. There should not be a difference. The question is whether or not they didn't receive a packet because they're enrolled in Magellan under the supervision of another provider. If you were listed as a Medicaid provider in the file that we provided to the plans, they did send us packets out to those, but if you didn't receive one, you can let us know directly at our dhhs.heritagehealth@nebraska.gov, and we can certainly share that with all three plans to make sure that they get that information to you. Can it be clarified? The next question is, can it be clarified if long-term pediatric nursing services, private duty nursing, are included in Heritage Health? And the answer to that question is yes. What's excluded is the actual waiver services, personal assistant services that are delivered in the home, or institutional long-term care services in the nursing facility or in an intermediate care facility for developmental disabilities. The private duty nursing is included in the Heritage Health scope of work. We're looking for the next question down. The next question is the webinar recorded and be available online? Yes, it is. Go to my Q&A. No, thank you. It will be available on that website and as soon as we can get it processed and uploaded. And additionally, we'll link to the individual PowerPoints so you can access those. At that, I think we've reached the end of all of the questions that have been submitted. Go back to the chat, make sure we haven't received any others. Oh, yes, we have gotten some more. So can you scroll up? Keep going. Keep going.
That's where we left off.
You sure?
Mm-hmm.
Okay, thank you. Sorry about that. The next question is directed to UHC. If you are currently participating with UnitedHealthcare Community Plan, do you need to do anything further for credentialing purposes? UHC?
Yeah, this is Jeremy, and no, you don't. You are credentialed and contracted.
The next question is, who would we directly contact with issues around credentialing issues we are having now with UHC? Jeremy, can you provide a contact information for questions regarding UHC credentialing?
Yeah, you can send them directly. Yeah, you can send them directly to me, and I will make sure to forward those on.
Can you give us an email address or phone number that they can contact?
Yep. My email address is Jeremy, that's Jeremy, _sand, SAND, @UHC.com.
Thank you. The next question is for all three plans. Will all three health plans have a time frame for payment of claims to providers? The answer is yes. They are contractually required to meet timely payment of claims. And I want to reference the exact language in the contract instead of off the top of my head. But I'll let each plan speak to their individual timeframes for payment, but they do have a contractual responsibility to meet timely payment standards. We'll start this time with UHC.
Yeah, so the contractual requirements around that are 30 days for electronic, 45 days for a paper claim. The average turnaround time that we have is for a clean claim is within 14 days.
And NTC and WellCare don't have current operations yet, but what we'll do is we'll get the information out of the contract and we'll share it. So thank you. We won't necessarily get through each one of those. But we'll be monitoring that and reporting on that. The plans will have to report to us their timely payment standards and performance, and we'll be monitoring that. The next question is, will applied behavioral analysis services be covered by each of the three behavioral health plans? The answer is yes. ABA is now a state plan service, as well as other behavior modification services that are covered by Nebraska Medicaid, and the plans will be required to cover those services as part of their behavioral health package of services. The next question, please explain when and how long-term care services are going to be rolled into this plan and how it will affect us on January 1st. Great question. Thank you for asking that. So as I mentioned earlier, and as Carmen mentioned during the initial presentation, those LTSS services are not included in the scope of the Heritage Health health plans, although those populations will have their physical and behavioral and pharmacy services managed by their plan. In January, Nebraska Medicaid published a concept paper for long-term care redesign to look broadly at our long-term care services and system to look at opportunities to improve it across the board. We recently signed a contract with Mercer Healthcare Consulting to come on site and do a thorough assessment of our long-term care programs and systems and engage directly with stakeholders and providers over the course of the next year to develop a plan for the redesign of long-term care services in the state. So at this point, we've not made any decisions of if or when LTSS services will be carved into managed care or Heritage Health, but that will be part of the assessment that we do during the redesign process. And you can learn more about that process, including the concept paper and those opportunities for stakeholder feedback at dhhs.ne.gov/LTSS. Any other questions? I think we've reached the end of all questions. I want to thank everyone for joining us today. We will be having another one of these webinars on June 29th at 10 a.m. Those details and the link will be posted on the website tomorrow at the same place that you saw this one. As I said, these materials will be made available on the website, and we look forward to please share the word with your colleagues around the state if they'd like to participate and learn more about these transitions. And in addition, the health plans will be doing outreach sessions to providers across the state as we get closer to the January 1st. I'll also say that as we gear up for the launch in January, we'll be starting later in the year with open provider conference calls on a regular frequency, including up to and after go live to ensure that we have rapid response capabilities during the transition to Heritage Health. Carmen, did you want to say any final words?
I would just encourage everyone to check back on the website. If you subscribe to that website, you will see our updates. That way you won't have to remember to check back. You'll actually get an alert letting you know that there is new information there for you.
Again, thank you for joining us. Have a great evening.